Hey everybody, my name is VJ. I'm going to be presenting the paper Complications of Renal Transplantation Ultrasonographic Evaluation today. Here's a little background information about the article. It's a retrospective review article, and the objective of the article is to explore the role of ultrasound in detecting renal transplant complications. Ultrasound is the imaging method of choice in the immediate postoperative period, and it's also used in the long-term follow-up of a renal allograft also. And it can also be used to guide diagnostic and therapeutic measures such as biopsy or fluid aspiration when there's a transplant complication. Complications can be divided into 6 main categories. There's urologic complications like urinomas, calculi, urinary obstruction, fluid collections like hematomas, lymphocytosis, abscesses, infections. There can be graft dysfunction like acute tubular necrosis, acute or chronic rejection, drug toxicity, or end-stage disease, and vascular complications like transplant artery stenosis, AV fistulas, infarction, pseudoaneurysms, or renal vein thrombosis, recurrent native renal disease, or neoplasms such as PTLD, other lymphomas, or renal cell carcinomas. PTLD is post-transplant lymphoproliferative disorder. Here's a little background about the transplant of a kidney. Usually the renal artery is taken with a cuff of aorta if it's taken from a cadaver, but no cuff is taken from a living donor kidney. And excessive dissection of the renal hilum and periureteral fat is avoided because that would compromise blood flow and blood supply to the kidney and the ureter. And the recipient external iliac artery and vein are skeletonized, and surrounding lymphatics are ligated. The donor left kidney is usually harvested, and it is flipped anteroposteriorly before being anastomosed end to side to the external iliac vasculature, extraperitoneally in the right iliac fossa. The article states that the living donor kidney sometimes is anastomosed end to end to the internal iliac artery, but this has since been discontinued as these anastomoses have shown greater incidence of stenosis than the end to side approach. Ureteral length is shortened. The ureter is usually shortened to reduce risk of ischemia, necrosis, or fibrosis of the distal segment. The distal segment is implanted with a ureteroneocystostomy with the small incision in the anterolateral bladder, and the ureteral mucosa is sewn to the bladder mucosa, so that's mucosa to mucosa stitching. And the bladder musculature is then closed over the ureter to prevent reflux. And typically the native kidneys are left in situ unless otherwise indicated. For instance, if there's a polycystic kidney disease, sometimes you can have a massive kidney, so if you do a nephrectomy in those patients, then you can spare up some room for the donor kidney. Here's an image of a transplanted kidney on ultrasound, and it appears similar to the native kidney, but you may note that the renal pyramids in this image are a lot more are more easily visualized than in the kind of the images that we've been getting, and that's more common in the renal allograft ultrasound. And color Doppler can be used to assess the blood flow in the transplant, and spectral Doppler flow is used to assess pulsatility index, resistive index, systolic diastolic ratios, and diastolic systolic ratios. And the bladder should be echo-free typically, and the bladder in this image can be seen in at the very deepest portion as the more anechoic area, right directly below the kidney. If the bladder appears turbid or solid, if it has little echoes in there, it may indicate infection or hemorrhage. 2/3 of urologic complications are apparent within the first month, and they're usually urine leaks or obstruction. There's a 10 to 25% prevalence of them among renal transplant recipients, and with 20 to 30% mortality. They're typically treated with a ureterostomy or a pyeloureterostomy, which is exactly what they sound like. And there's a lower complication rate if you do a ureteroneocystostomy initially. It has a 1 to 8% complication rate with minimal mortality. Urine leaks or urinomas usually present with pain, swelling, and discharge from the wound, extravasation of urine from the renal pelvis, ureter, or the ureteroneocystostomy site. And if there's leakage at the ureteroneocystostomy site, it's usually secondary to necrosis or the surgical technique. Urinomas are fluid collections of urine leak, and they can vary in size, and they usually present within the first 2 weeks at the ureteroneocystostomy site. On ultrasound, you should look for a well-defined anechoic structure with no septations that rapidly increases in size, and it's usually drained under ultrasound guidance. Uh, when you drain it, you'll find a higher creatinine level in the fluid that you aspirate than in serum, than the serum creatinine level, and that differentiates a urinoma from a lymphocyl or seroma. Other diagnostic tests include a cystogram, which could show leakage from the bladder, or a radionuclide tracer scan, which can show tracer in the area that was previously cold. So here's a picture of a urinoma, and it's demarcated by the calipers in the image to the left, on the right. And on ultrasound, you can again find that it's a well demarcated anechoic structure with no septations that's rapidly increasing in size, and on percutaneous drainage has higher creatinine than serum. And it's treated typically with a percutaneous nephrostomy tube for decompression, followed by stent placement if necessary. There's a higher risk of calculus disease among transplant patients than the typical person. They have a 1 to 2% of kidney transplant recipients will have a clinically relevant stone, and 15% of renal transplant recipients are hypercalcemic within the first year post-transplant, and that contributes to their the hypercalcemia can contribute to their stone formation. So a stone is suspected when the renal function subtly deteriorates, and the typical findings of renal colic in a patient with nephrocalcinosis is not as common in the renal transplant recipient because the transplanted kidney is denervated. So it's diagnosed on ultrasound, radionuclide scanning, and it's treated with a percutaneous nephrostomy tube, which can relieve the pressure and allow the renal function to stabilize. And an antegrade pyelography can then define the obstruction, and endourologic techniques can then extract the stone. Calculus disease can be diagnosed by ultrasound or radionuclide scanning. On ultrasound, you can see stones as a hyperechoic echogenic focus with distal acoustic shadowing, as shown here on the image to the right. And it can detect stones of all types, whether they're uric acid or calcium stones. Differential diagnosis for calculus disease is arterial calcifications, pericalceal fat, or crystalline calcial submucosal plex. And also you can see hydronephrosis if there's obstruction secondary to the calculus disease. Typically you can relieve the pressure by placing a percutaneous nephrostomy tube, and then once the renal function stabilizes, you can do an antegrade pyelography to define the site of obstruction, and then endourologic techniques can then extract the stone. Urinary obstruction is seen in 2% of transplants, usually within the first 6 months. The obstruction is usually at the ureteroneocystostomy site, secondary to scarring from rejection or ischemia. It can also be due to technical error during the ureteroneocystostomy placement or by kinking of the ureter. Less common causes are pelvic fibrosis, calculi, papillary necrosis, fungus balls, clots, or extrinsic mass compression. And it manifests as a rising serum creatinine and occasionally mild collecting system dilatation as well. Ultrasound can be used to diagnose hydronephrosis, as shown in this slide. However, interrenal edema and fibrosis are common with rejection, can mask hydronephrosis in some patients. And when you're doing the ultrasound, do it only on an empty bladder, since bladder distension could lead to mild, moderate pilocalceal or ureteral dilation by itself. And ultrasound also can reveal extrinsic ureteral compressors like the lymphocyls, hematomas, abscesses, urinomas, or anything else that could compress the ureter. Scintigraphy can also be performed, and it can reveal urinary obstruction. And normally there is good perfusion with prompt radiotracer uptake, but with hydronephrosis, the collecting system will retrain the radiotracer for 2 to 4 hours, creating delayed images. And the treatment for obstruction is with stenting and balloon dilation and extrinsic compression removal. And balloon dilation has a 90% success rate.